Time now for this week's Health Matters. Paul Critz with you, along with physician assistant Lynn Szabo. And we're talking about preventative health care, thinking about things before they get out of hand. In this case, the big C.
Yeah, cancer. I was inspired because, as you probably know, the Relay for Life in Crescent City is coming up on July 15th. So
that is sort of a tentpole event here in Del Norte every summer, too. That's a big deal.
Right.
Seems everybody, I'm always stricken with how, seeing everybody out there, when you see an article in the paper or something online about, who's taking part, all the folks out there who know somebody or are cancer survivors themselves.
Right. Yeah, absolutely. There's a lot of people up here definitely suffer from it. So screening's a good thing. And then the two community clinics that I know the most about, so UHS and Del Norte Community Health Center, they really do focus on it since the Affordable Care Act made most screening free. And there's also plenty of data to show that it saves people's lives.
Right.
But people, what's screening and what's risk is kind of different from person to person. So definitely should be talking to your provider about it. But the other thing is I noticed it gets kind of like pushed to the back burner a lot of times, and people decline to do stuff, thinking they'll get to it someday.
Right. And if it's not an issue, then...
It's probably worthy of a whole visit itself.
That's wow. Yeah, that's actually that's a good way to look at it, especially with how important and it's one of those like truisms about preventative medicine and how it saves you money and it saves lives. But it's not a crisis, so it's not always in the fore. Yeah,
and you kind of want to. There's something more comforting about denial.
Oh, yeah.
Like going with denial on that one. So if you don't have to think about it, then it must be okay, right?
Right.
But it's not. So the recommendations we're going to talk about today are assuming a person has average risk.
Okay.
And so you can figure out risk for different kinds of cancer kind of based on what you know about your family history, what you personally know about what you've been exposed to in your life, things like gender, race, age, things like that. But your provider might actually know a little bit more. So definitely click in with them and see what you can find out about what you might need. It is important to know that this kind of screening saves lives. The insurance companies wouldn't be paying for it if they didn't think it helped them in some way. But more appropriately, it can save somebody from a lot of what we call in medicine mortality and morbidity. So the first one is breast cancer. And this one I thought was kind of cool because there's an online model of what somebody's average risk is. Super easy to do, like 4 or 5 questions. It looks like it was mostly directed to women, but remember that men have breast cancer too.
Right. And the questions I assume are like family history and environmental and lifestyle questions as well.
Past medical histories. So, age, ethnicity, history of previous biopsy. They kind of have a yes or no about what the results are, good or bad, of a previous biopsy, when somebody's period started. So I assume that's, specifically for women, and when they had their first child.
Of age, like how old they were when they started menstrual. Wow.
Yeah, because that makes a big deal.
Right.
So anyway, easy to answer questions and helpful information about understanding what screening should take place from there. Okay. So they talk about your risks. They don't really talk about the screening, but you take a screenshot of that or write it down and bring it to your provider, and then your provider can use that piece of information to make recommendations for you.
What, that piece of information being?
What your risk is.
Okay.
So it not only tells you what your personal risk is,
right,
but it also tells you what average risk for your age and ethnicity, for your data points would be. And then you can talk about the 2 hot topics in screening for breast cancer. One is age of onset for mammograms, and one is interval between mammograms.
Okay, age of onset for mammograms. What's that mean?
Right. So when you get your first one.
Okay, just when you start. All right.
When I was 35, it was age 35, and then it went up to 50. And then now recently it's changed to 40.
Wow. Okay.
You're talking about average risk. Okay. And then it's every 1 to 2 years, depending on who you ask and what your risk factors are and where your comfort level is.
Right.
So maybe you don't want to worry about it. You want to get it done every year, and you want to plug in, and that's your routine, and you feel like you're at that point doing the best you can.
That's what my wife does. It's like every year mammogram.
Right.
Okay. Yeah.
Right. Screening mammogram. Kind of side note, there's a difference between a screening test and a diagnostic test.
Okay, that makes sense.
Okay,
Sure.
so somebody has a problem that becomes a diagnostic test, and weirdly, it takes a lot more time to get those done.
Well, I imagine there's a lot more detail oriented.
Yeah, a lot more detailed, that kind of stuff. We also have the option here of getting a 3D mammo, which is kind of nice. But that is higher radiation. They don't really say that. And maybe somebody is gung-ho until they hear that.
What sort of radiation risks, just across in mammography or X-rays, things like anything like that? What sort of load do you incur going in for?
I don't know if I could tell you the numbers, because you're really talking about a number of different tests.
things. Sure.
But eye-opening for me was, out of 100 abdominal CT scans that I order in my career, I give one person cancer.
Wow.
So if you go to the ER, if you have chronic pelvic pain or chronic abdominal pain, and you're going to the ER and you're getting a lot of CT scans, I think you should be a lot more critical about what the need is, what questions being answered, and whether it's worth the risk to you.
Yeah, yeah.
So, that's something to talk with the ordering doctor, who, by the way, doesn't know that you've had, this problem going on, and maybe had 10 of them over the last 10 years. So enlighten them, because that's an important detail to know.
Yeah, yeah.
Okay.
I think it gets forgotten. I think we just all, assume it's just kind of like space Star Trek stuff, and they're just looking inside us. And there's
I want one of those little scanners. Anyway, the other thing that's kind of important to know about all this cancer screening is there is a time period where you don't have to do it anymore, because maybe your age or your situation defines that you're kind of in a period where screening makes sense. And then you age out of it, or let's say something else happens in your life, and unfortunately your life expectancy it's usually 10 years.
So what you're saying is basically whatever
they kick you to the curb when you're about 75.
Because even if you get cancer, you're probably going to die before it kills you.
Right.
Right. Okay. All right.
Exactly. And I think that shocks people.
Yeah, it's kind of hard to hear.
I know. I've been doing pap smear clinics for Open Door, and I've been doing pap smears on 65-year-old women who've never had an abnormal pap smear. And
you're all like, ah.
And I'm like, all right, this is your last one, and their minds are blown. Yeah, because it's like, what? I'm not worth screening anymore?
You should throw some sort of like fake impromptu party. It's like, you won the pap smear. Yay. You don't ever have to get one again.
So it's kind of funny, but it's hard for that, because that particular group of women had it like drilled in their head. Must have every year.
Right.
So but the thing to remember is, it's not that somehow their lives are less worthy. It's just that we're looking at different types of screening.
Sure.
So actually, colon cancer being, and 74-year-old colon cancer is kind of a big deal. So again, your provider can assess risk by looking at personal or family history, whether somebody's had a history of inflammatory bowel disease like ulcerative colitis or Crohn's. I didn't know that, so that was kind of interesting. This is where the abdominal radiation history might come in.
Okay.
Especially that particular one was referencing childhood cancers and radiation treatment for, let's say, childhood, probably lymphomas or something. But it also, I think also how many CT scans you've had in your life, and HIV status, because HIV positivity is associated with more GI cancers.
Is there any understanding why? Or is it
it's
just
probably related to HPV, and it's probably colorectal cancer.
Okay.
So, but initial screening for colon cancer for average risk starts at age 45 to 50. So initial colonoscopy mostly around 50 for the average person, and it stops again at age 75, or as long as somebody's life expectancy isn't shortened by another onset of disease. So, and that assumes average risk. So if somebody has history of ulcerative colitis as a younger person, they're going to get, their screening is going to be a different recommendation.
Sure.
Again, I bet there's a tool like the Gale model for breast cancer, and I bet your provider has access to it. But this is cool. Not everybody is super excited to take 2 days off from work or the rest of their life. Spend that time in the bathroom cleaning out for a colonoscopy. And then even though you get good drugs, especially drugs that make you forget the whole thing, the whole idea of going into it is, not... It's amazing how many people put it off.
Well, they've got that other. There's another stop of screening before that, isn't there? Where they want you to mail in your.
Right. So yearly fecal occult blood monitoring is also almost as effective as average recommendations for colonoscopy screening in a person with average risk.
Wow. Okay.
So, but nobody wants to do that either. It's like poop, kind of out of sight, out of mind.
It's really hard to deal with. Yeah.
But yeah, we send a lot of those little tests home, and they never come back.
Yeah, because who wants to be seen dropping that in the mailbox?
Yeah, if you're neighbors with the person who works in the lab, maybe you just don't want them, up in your business.
I'm going to take it to the post office.
Yeah.
I'd like this certified, please.
But it saves lives.
It does. It's I'm making fun of it because it's potty humor, but I make
right.
I have one of those
cancer. What a the opposite of
that's not funny.
Yeah, it's an awful disease.
And I've got one of those, maybe two of those envelopes actually. Lisa and I both have one, just sitting in the bathroom, or just a daily reminder.
There you go.
To look away and go about our lives.
That's right. Going with denial on that one.
That's it. No, I need to stop that. I need to no longer deny. And I have a really, really wonderful mother who reminds me just about every other time I see her. Yeah. To send it in.
Yeah. She made that colon. She wants you to take good care of it. So the next one is lung cancer, and these recommendations come from the American Association of Family Practice Physicians. And this is cool because we have this in Del Norte. Here, you want me to repeat that? Are you shocked?
Say it again.
We have access, really good access.
I didn't know what this was. You said we have this in Del Norte. We have chlamydia in Del Norte too, but that's not something
it's
that
more like syphilis now.
Is it syphilis now?
God,
Has it changed?
Yeah.
Oh.
So this is an annual low-dose CT scan of the chest. In adults.
Annual?
Yeah.
Really? Okay.
Yeah, it can be. Of adults 50 to 80 years old with a 20-pack-year smoking history who either currently smoke or have quit within the last 15 years.
What's 20-pack year?
So for an example of a 20-pack year, it's kind of a lot of different math, but if somebody smokes a pack a day for 20 years, that's the easiest way to look at it. Like half a pack, 40 years.
Gotcha.
Yeah.
I gotcha.
So pretty easy in this community to find somebody who started smoking when they were like 5 or 7. Still happens. So, but the screening is not recommended because remember there's the trade-off with radiation to the chest, all right? Even though it's a low-dose CT. Screening stops if it's been greater than 15 years since somebody quit. And that's smoking cigarettes. That's not necessarily nicotine.
Okay, right. Yeah.
And I imagine this, although this looks solely at smoking cigarettes, I imagine things like cigars, pipes, and vapes are similar. So
what about cannabis? Is there any understanding about the...
Oh boy, that's a hot topic.
That's something I'd like to discuss maybe at some point.
I've thought about that actually, but it's not good news.
Well, no, of course it's not good news. It's smoke. But, you're breathing
so
smoke into your lungs.
There's so much about it that's bad, but, I come from Humboldt where most of the time I was there, we were like going with denial.
Right. So, you almost, you smoke pot. It's not going to get you sick, but it will. I'm just curious as to how it compares, if there's even any understanding.
Yeah, I'm giving a talk at the end of the month on pot and pregnancy for UHS Mothers Group. So, anyway.
I'm assuming you're against it. That's just an assumption.
It's not a good idea.
It's not a good idea.
Don't go there, ladies. Don't even be around it.
Oh, my goodness. Okay.
So screening for lung cancer stops if you're greater than 15 years out of quitting or... Again, if the individual has another health problem that shortens their life expectancy.
I have a relative who did something kind of interesting, and I'm thinking about doing the same thing when it comes to smoking, because Lisa and I are going on 3 months now with that.
Strong work.
Yeah, well, we still have the nicotine gum, and that gets you through. But like I have a relative who smoked and smoked for a long time and then stopped, and was good and clear and is healthy and is everything, but is older now, is actually over 75. Started smoking again because F it.
Right.
Can you get away with that?
Yeah.
Okay.
So if you get a catastrophic diagnosis, say, then why not?
Well, yeah, or
as long as you're not polluting somebody else's air.
Well, yeah, sure. That's the other thing,
and
that's something that's changed for smokers just socially in the last generation or so, which has made it easier to stop smoking because you can't smoke. Up here, I see more people. It never occurred to me. I don't see a lot of people in Del Norte smoking, of course, compared to in the past. Mm-hmm. But compared to elsewhere in California, yeah, I am surprised how many people I see smoking in Del Norte. Now, going to San Francisco, where I lived years and years ago, and no one smokes.
You don't even see huge peer pressure down there. Having a mom who just died in the last month of small cell lung cancer, mm-hmm. and misrepresented her smoking history constantly to her physicians.
Wow.
This might have saved her life.
Oh my God. Yeah.
But she definitely went big with denial on that one, and paid the price.
Right. It
was a vicious death. So anyway, the next one. So anyway, super easy to get this low-dose CT scan at Del Norte. You have to fill out some paperwork stating that you meet all these criteria, and your provider has to give the blessing, but super easy to get done. And they're recommending it annually for most people until they're greater, they age out of the 15 years.
Okay.
Or they find something, and then you got your answer. So the last thing's kind of interesting is prostate cancer, because a lot of men are super attached to getting their PSA done yearly. And I think our initial understanding, medicine's initial understanding of what that test was doing for people was that it was an appropriate screen for just otherwise average risk people. Uh-huh. But that's not really the question that the test is designed to answer.
Really?
This test is better for people who have the diagnosis and are doing like watchful waiting because they have a really mild form, or they're, seeing how they respond to, let's say, radiation treatment or surgery. And it's not really a screening test. It's kind of once you've been diagnosed, it's a monitoring test. But
okay.
We also don't have another test
really
that we can use for screening for prostate cancer. And I know it's a hot topic. My daughter actually did some study abroad, and she was in Spain, so she was in Madrid, and she was studying alternative testing that could be used as an annual screen for men, because that's fun for her during summer vacation. So,
all right. So what's a man? Let's just assume a man with a prostate.
Right.
What's he to do?
Well, they do this test, but here there's
a PSA, right?
Yeah, they'll do it because they don't have another.
Okay, so then how's it to be interpreted then?
So the first thing you have to understand, it might not be answering the question you're asking. So it's unclear whether it really helps for initial diagnosis. And I think men need to understand that. But maybe, so no certainty about this, it could decrease the risk of a late diagnosis. So it might actually be decreasing mortality and morbidity. Okay.
Just in a broader context over time, then. Okay.
But that's super uncertain.
Yeah.
But here's the problem: the risk of a false positive is significant.
Uh-oh.
Dun dun dun. Remember false positive?
Yeah.
And if somebody gets a false positive, let's say they maybe even monitor it a while, because I don't think any surgeon would act on just one high value. But let's say they go to biopsy, it's notorious that biopsy damage is significant.
Right.
In men.
Wow.
So, with problems in impotence and incontinence. So, it's if if you go there and you find out after the biopsy that you didn't need the biopsy.
Oh, wow.
Yeah.
Yeah.
But you're stuck with maybe having to wear diapers, kind of a thing.
Huh, man.
Yeah.
So, wow, that seems really... Okay.
Yeah, so not the best tool. Okay.
So then, I mean, is there a screening alternative then at all? Or is it just a matter
Not yet,
of...
but it's being researched.
Okay.
So
By your daughter?
Well, not anymore.
Oh, okay.
But yeah, by Spain.
Okay.
Go Spain. And I'm sure it's in the United States too. So there's also, and I've seen this personally, definitive anxiety of a possible cancer diagnosis that isn't really true. So
You've seen
going
what
back to
again?
the
What's
false
that?
positive thing.
Oh, you mean the anxiety of living with
let's say you're, Joe Average and you get your PSA and it's elevated, and then you're spending this time while the doctors and, referral to your urologist, which might take 3 months, and, deciding what to do, maybe
Right.
monitoring over a period of time. So you got to carry the anxiety with you
God.
the whole time for a test that might even not be a useful screen.
Right. And then even just the screening and the biopsy could end up doing more damage than what was
Right.
initially there anyway. So, wow.
Yeah.
Oh, my God. I had no idea.
Yeah. So, but if screening is done on an average risk individual, it typically starts at age 50 years and continues every 1 to 2 years. So a PSA starting at 50 every 1 to 2 years for an average risk individual, with the caveat that a false positive brings risk. Okay. But things that increase risk, this is kind of interesting, is somebody who has a BRCA gene. So BRCA genes are kind of cancer-oriented genetics that we looked at mostly for breast cancer, ovarian cancer, and colon cancer. Now seems to be kind of a player in prostate cancer.
Wow.
So the black race is a risk factor. Positive family history and a primary relative. That means like somebody's brother or father.
Okay.
It doesn't mean your cousin.
Okay.
Okay. So it's the people you probably eat Thanksgiving with.
Okay.
So a primary relative with a family history and a primary relative increases risk, especially if that individual is under 65 years of age when they're diagnosed.
Oh, wow. Yeah, sure.
Yeah, that's pretty common. So, and it also, other things that cause false positives, if somebody's had an infection or some instrumentation, like a digital rectal exam, PSAs can go up.
Wow. Okay.
Yeah. And you stop screening again if the life expectancy is less than 10 years or about age 70 to 75 years old.
Okay.
Okay. So like I said before, I think it's worth to have a single visit with your provider and talk about are you touching all the bases with your screening. There's probably other screening too, like
I was wondering about
which might change if somebody, say, had higher risk. Let's say somebody has the BRCA gene. They should definitely, and a woman should be screened for colon, ovarian, and breast cancer probably more rigorously.
What about, I mean, I was just thinking you're going through all skin cancer, which is a big concern nowadays. I mean, screening, you're just basically going and having somebody look at you, right?
So screening is, Jesse Voss, the dermatologic PA in town, does a really, really great job at this. And so do many other dermatologic offices. And they pretty much get you naked in the exam room and they look at every little bit of you. So it's kind of embarrassing for people and invasive, but if you go every year,
you get used to it.
Yeah, you get used to it, is right.
I get there's a story about a woman, and I think she was either a dermatologist or oncologist or something, just on the just a chance thing, found melanoma in her navel.
Right.
And it was no place that would ordinarily even get looked at.
But
but just
melanoma, I know a physician who's actually worked in the local community a long time who had it in the retina of his eye.
Oh, my God.
I know. Like, I look at my retinas every day, right?
Right. Yeah, right. Oh,
No,
yeah.
not. But, and he's doing fine.
So now, access to this sort of screening, excuse me, how does somebody get to, in Del Norte, is there any difficulty that you see anybody getting access
Yeah, the
to
biggest difficulty. So what happens, you get put in the room, you're going there because you've got a routine diabetes checkup, and the medical assistant is going, should we order the colonoscopy for you again? Are you going to do it this time?
Right.
Should we do this? Should we do that? And the provider oftentimes is more focused on what we call the chief complaint, or the reason that the patient's there, and kind of assumes that all these other boxes are ticked by somebody else. But I think it makes sense to have an appointment solely to focus on this, to define risk, decide what tests you need, order if it's, if it seems reasonable in time, and then move on to the next risk. So, but I've never seen that happen.
Does the culture exist for that? It seems like I'm thinking about how you described how an ER is meant to work, about how here you've come in, you're on fire, we put the fire out. Somebody else deals with the burns, we put the fire out. And that it seems like if you're in an exam room and the person in there with you is just dealing with your chief complaint, it seems you never get a chance to just kind of sit down in the healthcare system and go, here are my concerns. Here, what are your thoughts? You don't really get a chance to have that coffee clatch sort of sit down. Let's talk over big. And screening seems to fall into that
completely, because there's an element of denial.
But also an element of not
and
being an emergency.
7.5 minutes.
Right.
Easy to just turf off to the next visit.
Right.
And oftentimes people will not understand how complex it is. And they'll go, I just want the blood test for cancer. I just want a cancer blood test. And then you have to spend your time saying that's not how it works.
Take off your clothes.
That's only in dermatological situations.
Oh, okay.
Well, no, I guess actually a pap smear.
I got to change dentists then. No. I know what you,
right.
It isn't, people just have
There's changing recommendations. So I didn't put pap smear on here because the recommendations, the screening for pap smears has improved so much from the time, that I first entered medicine. And now that we don't have to screen women as often, as long as their risk is average. So when we used to do pap smears, we used to kind of spread goo on a slide and then spray hairspray on it.
Really? Okay.
That was the fixative.
Okay.
And then send it off to the lab, and then they would look at it under a microscope and say thumbs up or thumbs down. And so now what happens is they actually look for the DNA related to HPV virus or human papilloma virus. And then they have I think it's a computer, so some type of AI probably, looking at the actual cells under the microscope. And then the pathologist reads either the more complicated ones that are flagged or a random assortment of them to make sure that the machine's reading it correctly. And right now it used to be must have pap smear every year, and now it's like maybe 5 years.
It seems like the colorectal stuff. It seems like the bars moved recently too, as far as ages when things would be needed. And this is something that I think a lot of people see. And again, it comes back just the kind of mindset of the patient. They see these things changing, and you go, well, okay, well, they keep changing, they keep moving the goalposts as far as when you have to have this screening, this test, whatever. So they don't know what's going on. So why should I bother with it? And that is just a fundamental misunderstanding of how science works, right? Because
no, science refines constantly.
Exactly,
constantly questions, constantly. I guess you could say self-inspection.
And if those goalposts are moving, that seems to be indicative of like robust science.
The new kind of screening for pap smears is a huge advance. It's absolutely enormous.
Right.
So, I think maybe a yearly visit, or maybe every 3 to 5 years, depending on your family history and stuff, with your provider solely dedicated to this, would be good.
Yeah. Wow. And again, like as we always, probably the most important takeaway from Health Matters that I've gotten from this, you are your own best advocate.
Absolutely.
You have to know this stuff, and you have to have the courage and the confidence and the desire to speak up in the exam room in that 7.5 minutes and make your concerns known.
Right. Absolutely.
All right. Well, go out and get screened then if you haven't already been screened.
Get screened and walk on the Relay for Life on July 15th.
There you go, because chances are somebody whose life, if you aren't somebody whose life already has been affected by cancer, somebody whose life has been affected. So
I want to add one other thing about a different topic.
Okay.
There was a longtime emergency room physician in this community, Dr. James Holmes, who passed away recently. His service is on the 29th of July, which I believe is a Thursday, from 2 to 4 at the Cultural Center.
Oh, wow.
We owe, as a community, we owe this individual a debt of gratitude.
Really?
He was one of the best and brightest. And as we say in the biz now, he's off call.
Oh, wow.
So anybody who remembers Jim Holmes or got $5 from him to go get food or saw him 3 times in the ER in one day for 3 separate complaints, he loved this community and he always hoped for better for everybody. Wow. So we'll miss him.
Wow. Wow. Definitely. Well, thanks for that. Thanks for that sentiment. Yeah. All righty, Lynn, any idea about next week's Health Matters?
No, not really.
Okay. Whatever happens, we'll talk then.
Yeah, maybe syphilis.
Always leave them wanting more.
I know.